Try it. I know it feels like it's been through it. Now I'm going to challenge your occiput. So I'm doing a dynamic challenge that works. I can breathe in. Breathe out. Okay, so he strengthens on the out breath. That's kind of weird. So I'm going to adjust. That did not move. It did not move the way I wanted. So I'm going to take it another way, and I'm going to see if I can hold the occiput with my left hand, and then kind of, there we go. Make sure they talk. Sometimes it changes their body. Good. There you are. Eyes open. Good. Okay, so that doesn't show, at least not spine. That's good. Okay, now I so sacrum seems to be. Now I kept talking about this thoracolumbar thing. Should I address that? Yeah, I'm going to go in here and static challenge. Again, I'm sorry, a dynamic challenge on. And I'm just going to basically, right at the T12L1, I'm going to do a supine sort of osteopathic style adjustment. Lift your head. It's the one you guys all learn, I know. Now, the key with this, now if he's small enough, I can kind of really get control of his breathing and let it go. I'm right underneath T12, and I'm rolling up and giving him a little shot. Good. Sit up. Yeah. Doesn't really want to sit up straight. Okay. Yeah. You have water with you? Good. Eyes up to the left. Straight ahead. Eyes closed. Take a breath in through your nose and out through your nose. Half breath in. Remember from last session? Half breath in. Full breath in. Half breath out. What's he got? Half breath. Remember, vasovagal is a forced inspiration or expiration. Somebody probably said it, right?
Temporal bulge.
Temporal bulge, thank you. Whoever said that. Temporal bulge is a trial of the. So the temporal bulge often it's found by having a half breath in, strengthening a weak, in the clear weak muscle. But it will also show up with a strong indicator. Now we could have done that when we were doing weak neck muscles, but now we've gotten rid of them. Neck muscles. So I need to fix his temporal bulge. And I don't know which side it's on. How do I determine that? There's several ways. TL. Yeah. So just TL right at kind of at the TS line. That's where the bulge occurs between that temporal bone and that parietal. So half breath in. Okay, so that kind of verifies I got enough. So go over to this side and just see if that. Now that, oh, that really shows. Yeah. Now half breath in. Take a full breath in. And half breath out. So that's the parietal set. It negates on the breath out. Now sometimes you can just see them. Good land back. It's kind of dark in here, but comfort level here. Sometimes you can just see them, but honestly, I'm not seeing a real. Sometimes it'll just be so obvious. They call it banana head. honestly, just now looking, it almost looks like the temporal lobe should be on this side. In fact, it is. I think I was fooled. Yeah, it's okay. So we're gonna go with that. Okay, hold there. Keep that right there. That's my indicator muscle. I'm gonna challenge his right bulge, and I get lucky. So so keep that right there. I'm gonna challenge the bridle side, the bridle descent side. So let that go. So that's how my correction is going to be. I could really dial it in, maybe muscle test to see exactly, but I kind of go more by feel. But that's really the most, especially when you're learning, that's the most diligent way to do it. Is like you kind of push this way and maybe this way and find where you get the real clear reading. But usually it needs kind of this and this. We did this last session, right? We did temporal bulge last session. Breathe in deep. In breath, and I should be correcting on a half breath technically. Breathe in, half breath. I usually go, I just have them breathe the full. But normally you'll correct on the half breath, just like the way you found it. It's too challenging sometimes for me to explain to the patient what a half breath is. A lot of times it's hard. A lot of them can't even, they don't even know the difference between breathing through their nose and mouth. So I kind of take my battles, breathe in, and on exhale. Now I have, you see my thumb here. I'm crossing his sagittal suture. So I don't want to do this because I could jam the sagittal suture. I could lift his bridle bone and then jam the sagittal suture in the process. So a lot of times I'll do this. Sometimes I'll cross my thumbs like this so I stabilize the sagittal suture, and then I just kind of like. Guys, any of you guys? I think I've mentioned this. Any of you guys South Park fans? The Canadians, all their heads all pivot. That's I can think. So breathe in and breathe out. That's a crazy show. It's so weird. Breathe in again. And let it go. More time. Breathe in breath. As he breathes out, you'll feel it kind of give. Let's just colors better. Half breath in. Out. Full breath out. Forced breath out. What's that? Section 2. Forced inspiration or expiration is a. So it's like the inspiration expiration assist. Touch the. So we have gloves. Here. Oh, it was we were at dinner last night. I was bragging up this movie that we saw. It's Harold and the Purple. Harold and the Purple Crayon is the name of the movie we were talking about. Anybody seen that movie? Huh? Someday you can watch animated movies. Like, I think I might have probably these might be a little smart. So they were really tight. Okay, good. Give me a strong indicator muscle. This is we all will do, and then we'll get a strong indicator muscle. I'm going to go to the actual correction spots that are right on the left side of this cruciate on the challenge, like I was going to correct it this way. And I'll go to the other side. Sometimes I do both sides. Sometimes it's just not that clear, and I know that. Definitely the left side. And where was his statement? Left side. Where was his oxygen? Left side. But his atlas was over on the right. Now relax your jaw and interlace your fingers and breathe. As he breathes, the first couple, as he breathes there, I'm loading a little more. There we go. And I'm looking for the give. Sense of motion. There it is. His cruciate's moving really nicely. His temporal bone, or his mastoid, is still kind of stuck. There we go. Holy cow. Whew. Now, again. Yeah, they did that. Like that. Now it's. Whew. I hope you guys have done enough of these that you felt that. Because if you keep doing these, at some point you'll feel that motion. You haven't. Keep doing these, practicing. Okay, now, yeah. Doing bilateral PMC because that is the most sensitive muscle test approach to anything. ALT, it requires both sides of the brain. So breathe in, full breath, full. Breathe all the way out, all the way out, all the way out. Please rise. So maybe drink some water and just maybe chill. In the dark. My eyes are working now. Is that? My eyes are working. Oh, good. Well, maybe you're ready to go. I definitely feel like you need. My eyes are back. Okay. Looking good. Okay. So anyway, if any of that makes sense, hopefully all of it makes sense. If you follow my logic for the most part. If you didn't, if you had, if something didn't, if you like, how did you get from here to there? Please ask me. And there's other stuff you probably need, but for right now, we didn't test the nutrition. But for right now, water and just chilling. Water and chilling. I can do that. You had a big adventure last night. Lots of driving and late probably. Oh, yeah. But you already had my drink. Oh yeah. They're always. Yes. Thanks for letting us utilize. So I know some of you are treating patients all the time, and some of you are not yet. Maybe I don't know, but are any of you using this stuff yet on people? Do I? On patients? On family?
Yeah.
Yeah. Yeah. Anybody that'll stand still. Yeah. Get them cornered. That's how you. Yeah. You'll find out who your real friends are. I've told this story I think before, but my cousin's husband, who I'm really close buds with, he's this giant dude, and I've worked on him years, decades, and he's just an awesome worker. And when I first started learning AK, I started trying to muscle test him, and he's one of the most difficult people I've ever muscle tested. He just is for lots of reasons, but. I got to where I could muscle test him pretty effectively, but Normally, and I honestly have no idea what I've ever really done for him, but he comes in like every 2 to 4 weeks. He he's just totally into being treated. But I can hardly move anything on him. He's really stiff. He's really huge. But somehow I can't get rid of him as a patient. So, if your friends and family that at first you feel like you fail on, you might end up stuck with them, which is fine. But anyway, so I threw some of these slides in because they were laying around just in case we wanted to review the muscle test, basic muscle test approach. Always review this in your mind. Let it pop up in your mind when you get ready to muscle test. How's my contact? How's my own energy? How's my own breathing? Is a good place to start. Where am I stabilizing the patient? Am I creating any kind of factor that might interfere with my muscle test? I've been doing this for decades, and I still have to do this, especially first thing in the morning. I have to kind of dial myself in, where I start getting kind of ham-handed. Make sure you're paying attention to what your patient is experiencing and what they're doing, if they're holding their breath. I didn't really notice Dean holding his breath, but definitely had cranium stuff. TL, quick review. The more of your pads, the better. Because TL is an electromagnetic mechanism. So you want to maximize that. There's more energy in the pads than in the tips. Challenge, just a quick review. I've got several slides down the line on other kinds of challenge, just kind of some conceptual stuff. But remember that every time you touch a patient, in essence, you're challenging skin receptors, maybe stretch receptors in the skin, pressure sensors. You might be on a place where maybe they got bruised playing with their dog or something. Make sure you know where they have scars. You take a good history, you know they've had shoulder surgery. So there's going to be, when you get there, you can be aware that there's going to be scars that may give you an abnormal response. And dynamic, static, you're using a lot of dynamic with Dean. Started out doing static on his sacrum, used a straight P to A, statically held it there, and the psoas turned off. And then I used a strong psoas and challenged it dynamically, and we got an opposite but supporting response. Anyway, this is last session. Any questions on any of these? You guys remember all these? We didn't spend too much time on the spinal terminal lift. It's basically, you just do a good job on the sacrum and the pelvis. Usually this will take, and the cranial, usually this will take care of itself, unless they've been damaged there. Guys, any questions on fixations? You remember fixations versus subluxations? Subluxations will therapy those lumps. And the subluxation often is a lone vertebrae that's just all out of whack and really in trouble. And a small TL will often find it. That you'll like one spinous will TL and the one above and below won't. With a fixation, it's going to involve 3, sometimes 4 vertebrae. So it's a broader area. A lot of times it won't TL. A lot of times the spinuses won't be tender so much. But if you TL and create motion, that'll bring it up. We didn't have with Dean, like with the lumbar fix. We never did it. No, we did the thoracic one. Just doing that without him TLing it, gave us a change in the neck extensor frame. Retrograde lymphatic, where you tip the patient up, and mainly you treat the pec minors. I test pec minors all the time on people just to kind of screen for that, because often it's involved in their postural distortion and shoulder issues. These were the first couple session muscles. We covered a lot of ground, if you think about it. Any questions? questions on any of these muscles? If we get a chance, we can review them. This is last session. This muscle right here, serratus, very, very important muscle. They're all important, but the serratus is what I would consider a big ticket, like the psoas. Psoas, serratus, lat, the pecs, they have a lot of different attachment areas. The big prime movers. They have a lot to do with posture and core stability and all that. So there, a lot of times, if I don't know where to start on a patient, I'll just start testing all their major players. So as glutes, pecs, just the big guys, deltoids, and look for, and that's a lot of times how I enter into the process. If the posture isn't giving up much. These are our new muscles, and the first one we're going to do right off the bat, get warmed up. Love this muscle. It is quadratus lumborum, and it's often overlooked. And I like it because it sounds like a legal term, like a Latin legal term. Erector spinae. This one is interesting. We test all these individual muscles, but all these muscles in the back, we kind of like get too lax. I'm going to show you how we test them as a group. And then look at all the rest have to do with the lower leg and foot. So this is big lower leg, foot weekend. Next session is going to be shoulder, elbow, wrist. And then I think we get into knee after that somewhere. Anyway, we're going to drill down into the foot. You guys are going to all know more about evaluating the ankle after this weekend than you ever did, and probably a lot more than most chiropractors I know. Certainly more than most naturopaths and MDs I know. I don't know why years ago I got obsessed with the foot and knee when I was in my first year at chiropractic college. It's just never let go. And then we're going to learn about reactive muscles, and we're going to go more into switching. I'm going to show you some other kind of more advanced, I guess you could call them unswitching techniques. Ocular lock we learned about early on. Ocular lock is a really good way to sort of unswitch people. Doesn't necessarily help it doesn't help you necessarily get to all of the factors that might be switching, but it will clear them so that you can dive in and do other stuff. It will, and I'll show you a couple other techniques where you don't have to adjust the upper cervicals necessarily to do like a quick unswitching. They're kind of old classic techniques. We're going to learn, and what's fun is we're going to do the foot muscles, which are all sort of, of course, innervated by the branches of the sciatic nerve. We're also going to learn about lumbar discs. We're going to learn about cervical discs, and we're going to learn about lumbar facet syndrome, which everybody calls it facet syndrome, but AK would call it facet imbrication, which is also correct. But we're going to learn how to fix facets. And a lot of times when you're adjusting, like that adjustment I did on Dean's time, I'm mostly opening up his facets. I'm not having much effect on his discs in that kind of adjustment. And a lot of lumbar side posture adjustments, we're really addressing the facets as far as the articulations more than anything. And then reactive muscles. Somebody asked me last night, so what do you think? I think Caleb was saying, what are the techniques that you really think are, they're all valuable. Some of them I don't use because they take too long. There are other ways, faster ways to do it. But it's important you guys know them to understand the process. But I would say reactive muscle is one of those that I use every day. It's
really very easy to fix. You're going to learn about that. Switching. So we introduced this session 1 or 2, how if the body, we're relying on the body to give us clear information when we're muscle testing. We're with what we know about biomechanics and normal responses, we're basing the body's conversation with us through AK on those reference points. And we're sort of assuming that the body is going to respond a certain way, but often it doesn't. It doesn't respond because it's out of it. The thing you're testing is out of calibration. So that's basically my understanding of switching. So in extreme cases, well, actually, Dean kind of had this a little bit ago. I really thought he had a temporal bulge on the left. And it really acted like that, but when we really got to look at it, it was on the right, clearly. And so that's, with the testing I was doing when he was in different positions, kind of indicated it was on the left, but in reality, it isn't. And we know that because after I corrected it, a bunch of stuff cleared. If I'd have corrected the wrong side, it wouldn't have cleared, most likely. So you've always got a way to retest and see if maybe you did it completely wrong or did it on the completely wrong side, and you'll know because the stuff, the findings don't resolve. So what causes switching? Anything. Chronic stress. A lot of times people have maybe a chronic foot issue, ankle issue, knee issue, and they spend a lot of time on their feet. Their body is in compensatory mode all day long, dealing with this genetic problem. So it will cause them to get neurologically disorganized, which is really a better term for switching, because it isn't always switching. It's more, sometimes it's just fuzzy information. So these are various terms that get thrown around a lot. Can you see this? I just realized this.
Oh, yeah.
These are terms that get thrown around. These are K27 and cross K27 were the first protocols that in AK that were developed to address switching. And then they got into looking at cross crawl and gait patterns, and we learned how to test people in gait, right? The inhibitory muscles in gait. We learned that in section 1. So this all ties in with that. We're going to learn how to test people with cross crawl to see if cross crawl is actually strengthening them or weakening. And we all know people who have gone through various cognitive trainings, like especially maybe as kids, some of you did, where you did cross crawl exercises to help focus and all that. They didn't have any of that stuff when I was a kid. I'm sure I would have benefited from it. And then we have all these folks that are out there walking, power walking for exercise. Sometimes they're driving their dysfunction deeper into their system. Their walking is actually not helping them if they're switched on that level. And I'll show you a way to test for that. There's a technique here. This is one I never use, but it's kind of interesting. It's Dr. Goodhart came up with this years ago. It has to do with various reflex collections of receptors that have to do with neck and pelvic coordinated movement. Once again, it goes back to talk about dural torque, where the dura attaches firmly. Cranium C123, and then S2 down to the coccyx. So things that when things seem off, that's the first place you want to look for the dura attaches firmly. And the same idea with, these are very specific reflexes that we'll go over, but it's the same idea. So anything on the triangle can cause switching. People who are, I have patients that they cannot tolerate caffeine. They just can't. It just throws their bodies into a tizzy. And, but they drink. So they're always in a state of imbalance physiologically, which will eventually manifest in physical changes. It's amazing. I've seen people, they go off something that they're chronically ingesting that's toxic, whether it's smoking, coffee, or alcohol, or whatever it might be. And the thoracics that I could never budge just open up. And I've seen that happen so many times over the years. It's just amazing. And I can tell when they're back on the crap, whatever it is that they're on or off, because it comes back again. It's really, it's so physiology comes anatomy. Anyway, so when you guys are you've been testing enough now that you're starting to probably, hopefully, feel comfortable, at least kind of the basic approach to testing each other or your patients. And if you're like everything's weak or it's weak and it's strong or just doesn't make sense, that's when you start thinking, we're switched. And that's when you go to ocular lock, you go to cranials. I'll show you how to do a quick scan for K7. Anyway, these are all just indications that you want to check for switching. To some stuff talks about, we can get exposed to all kinds of things, emotional trauma, chemical trauma, any of these stages, and it can kind of throw off instead of our nervous system nicely developing and optimizing and expanding its function, it goes into like freeze trauma mode. This can happen even before we're exposed to the things that are deemed as a threat to the system. So there's one that I don't do. Dr. Francis used to do this. It was kind of fun to watch. He would have people read and test them, and if they weakened, then he would find out what was causing it and fix that. And they'd have them read, and then they'd have them read backwards. I don't use that. It's interesting, but it's kind of too tedious. A real quick screen, and we'll have somebody come up. Anybody who's normal, or anybody who maybe feels a little off this morning, if they're just not quite there, somebody come up. Now, I'm going to do a couple of things. Let me have you sit first. And so, take the shoulder. That right there. Good. Yeah. Go ahead and look straight ahead. Good. We won't do ocular up, but we could do that as a screen. Go ahead and turn your head all the way to the left. Turn it all the way to the right. Good. So all the way to the right, and then eyes all the way to the left. That's pretty good. That's pretty good. Now eyes head to the left. Eyes to the right. Yeah, she totally doesn't have that. So that's now. I want you to hang back for a second. There's another way to screen for switching. And we played around with the K27 thing. I showed you kind of the quick set test. Hold that right there. Okay, so I'm just looking for a strong indicator. Hold there. There's a couple I can use. Now, keep that handy. Fingers from each hand. Press gently. And that's good. Now, I can cross your hands, but don't touch them. Touch those points, but don't touch them. No, you're good. You're in good shape here. Anyway, thank you. I need somebody that's not quite as top form. Somebody who hasn't done their yoga this morning. Energy. Really? Oh, you are. So we'll start with the K27 one. Now, 2 fingers, right? K27 is right where the clavicle meets the sternum. You drop your fingers right off that. Well, if you go to the sternal notch, you're too far. You back up a little bit, let your fingers drop right off, and you're right at the first rib, clavicle, sternal junction. And that's K27. Those are mastered. They're kidney acupuncture points, but they're like, so that weakens, right? So now what do we do? Right? If she weakens to that, then now I would want to drill down and find out what's behind it. Yeah, keep that there. So I'm testing her umbilicus. This is the old test that was developed in AK way back. No, that's not showing that way. That's interesting. Let's go to just below that. Oh, here. Don't have that. Okay, go back to 227. Now, you said you've been busy. That's not. So that's not all. So she's been feeling ears and a little bit of vertigo. Okay, so where do I start with that? Well, any number of ways, but because we know she's experiencing something in her because of our history, why don't we start with you taking a breath in? Hold it, yeah. So you have them continue to, you don't have to push very hard. Just, okay, so breathe in through your nose, hold the breath, and then breathe out. Okay, breathe in through the nose, hold, breathe out through the nose, out through the nose. Okay, so her breath in negates the K27. So let's do this. Hold it there. Head to the right. Yeah, all the way to the right. Ice to the left. Head to the left. Ice to the right. There you go. But that doesn't show. The K27 does. So I could just go straight to cranial, and because it was just a straight inspiration assist, I could find out which side it is by having you touch here. She's right on the place where I would do the inspiration. Now go to the side. There it is. Okay. So go ahead and reach around this way so we're not. Yeah. Okay. So it's on the left. Okay. So remember the first cranial we learned right behind the mastoid, supporting the head. Breathe in through the nose. As she breathes in, I'm pressing forward on the mastoid. Now, a spinobasal, I'd be doing that, plus I would be pressing north on her palate. So I'm pressing on the in-breath. Now, you remember from cranial motion, I'm going against, remember, the normal motion of the mastoid on in-breath. Trying to build the tension and spring so it'll kind of spring back to where it needs to go. Now, I just want to go back and see. Okay, breathe out. Make sure we're not missing something. No, so that's good. Now, do cross K27, which is like a deeper. It's like going from inspiration assist to spinobasal. This is like K27 to cross is like a deeper. That doesn't show. So now she might have, close your right eye, close your left eye. She might have optic lock, eyes up to the right. Okay. Down to the left. Down to the left. So the left eye closed. So there's an atlas going on there. So, and you said ears. Maybe you know, I do it. You guys learn how to do endonasal techniques in school here? Stretch that a little bit. With your left eye. Okay. So now she's ready to really test. I mean, her body, we know we can kind of trust what it tells us. We had to treat her a little bit cranial to get there. Oh yeah, they're locked up. Those people are. That's how my cousin is. He's everything's strong. So you have to really work to find a weakening. And usually when they're holding like that, they're usually holding their breath. They're super, super good at holding their breath, locking up they raise their intrathecal pressure, and that just freezes their nervous system, so it becomes much less responsive. These people are tough to work on. So yeah, but you know, a lot of times when people, everything's strong, just back off and make sure you've explained to them what you're doing, especially with men, guys. They hate being weak, and so I have to go through long diatribes with my macho male patients, you know, to let them know that, you know, because it's like they think any sign of weakness is bad, and they don't see it as helping get me in. They see it as a contest. When I'm muscle testing them, we're it's a strength contest, and so you want to avoid that. But usually, most people are reasonable, and they will they'll understand why you're doing it. The best thing to do is find a way. If somebody like that little flip K27 thing, which isn't really official AK, I use that all the time. It's that's a really cheap, quick screen. Somebody come up, I'll show you. We've done that, but we learned about priority, right? So looking for a strong end. Just my two fingers like that. See, my polarity should be kind of running this way, and shouldn't really disrupt her. Ooh. You've got, yeah, so she's switched back up. Yeah, so see when I come in like that. So that's a cheap 5-cent. I'm going to see what that negates it. So she turns her head. So yeah, we have to drill down into this. Sorry. So normally, let me hang on to that, but let me somebody else come up. Anyway, anyone who wants to stretch their legs. These are often ways to do that. Now, his body will adapt to that, but if I hold the hand, but just that little twist disrupts the perception vessel gritting that we can see. First, this should test strongly, and that really should disrupt it. Kind of like if you do things like that. And these are little tricks that people use to sell vitamins. See that all day long. So you can do that on your really hard to test people, or you know, if you try to get them in your on your side, so to speak, just find something that will and then they're like, oh, wait, let me try that again. I wasn't ready. Let me try that. And you do it 3 or 4 or 5 times, and pretty soon you got it. Thank you. That's, and I would say probably 1 to 2 out of 5 people have some, probably 2 out of 5 people on any given day in my office, probably 2 out of 5 people have some notable, treatable piece of switching. Whether it's, usually it's tied in with the cranials and all the other stuff that you're working on.
I give the K-7, but for the umbilicus, what would you do?
Well, that was like if that tests, you know, if you get a weakness from that, then you treat that. Basically, the old treatment when they first were learning about switching, they would just rub those out, and somehow that would kind of recharge the electromagnetic system, and they would unswitch long enough so they can start their other testing. And that's, you know, you can use that method. It's a quick fix, but it doesn't necessarily point you to where the fixing, where the switching came from. When I treat it, you just have the patient TL it first, and if that, like, she didn't go weak, but if she would have, then I would have. And what I do is I rub just above the belly button, the umbilicus, and at the 1K27, and then you switch over. And a lot of times they'll be tender. They'll be real tender, and the tenderness will go away. These are very powerful, very important points in the body. When we talked about gait, we talked about how important it is for this motion. I'm exaggerating this, you can kind of see it. How important it is for this motion to be part of the gait process. That's the K27 they're the associated points for the spine, for the whole spine. Anyway, so that's one way to screen. This is what we just asked about. This is correct by stimulating points. Therapy, but if they don't therapy localized, don't treat them. And then this is another old, if any of you guys were familiar with the old Touch for Health system, which is basically AK for the adjusting part. We'd have patients do CBG, GB switching. So it's another kind of switching. And same thing. You just basically go to the ends of those 2 meridians. I don't do that. I never do this. Sometimes, once in a while, I might check for that, but usually I do. But it's another way to sort of ferret out switching. Cross crawl. Dr. Robert Blake was my first official AK teacher. He does a lot of work with switching. He numerous times said it's one of the most important things you can do with your patient is to get them unswitched and then go from there. But what I learned from him was having people do a series of cross crawl motions and then testing for muscle weakening or muscle strengthening. Somebody else come up that hasn't done enough, or maybe anybody else, somebody wants to stretch their legs. Oh, here we go. You have any issues with your ankles, knees, or hips? So what I'll do is I'm going to test some big player muscles here, and I'm going to note. Then we have a slide on this too. So tell me what I'm testing. The upper division of the
Serratus.
Thank you. Serratus anticus. That's that. Middle division. Lower division. So, okay, so what's this? Last session. That's the lower tract. So it's almost the same starting position. Turn the head and then, so yeah. So serratus is strong. Both sides. We could do double check her scalenes, make sure they're. Let's do your neck extensors. Okay.
Yeah.
That's good. Okay, lean back. So I'm doing like several big. I could do lats, big players. Very nice. Okay. So there. So as wow. Here. Out. With me. What am I testing? Give up. What am I testing? Practice. So that's enough. That's a bunch of stuff. Now I want you to stand up, and you can have your patient do it on the back too, but it's much more effective. I want you to do about, and I'll do them with you so you don't feel silly. I want you to do about a dozen cross calls. Now here's how I want you to. You just follow me. So now there's lots of different methods. People do these things like this, and for cognitive, and there's but I have people just do a straight cross crawl, but I make sure they're moving here, and I make sure you're looking straight ahead. But I want you to walk. Well, you can look back if you want. See what you follow me. So so they can see that. So basically, you're going to do this, and slow enough that your nervous system, you're giving it a lot to work with. I'm not counting. Say that's 6, 7. Good. Now she didn't have any weak muscles, so a lot of times the cross crawl will turn on, at least temporarily, weak muscles. Push, push. It's globally weakened. It turned off every muscle in her body. Sorry.
No, it's okay.
We'll fix it, I promise. So she was great. All of her muscles were fine. And she cross-crawled 15 minutes. And that's like, that wouldn't even be walking out to your car. Maybe walking to your car 15 strides. I don't know. So now, before I lose the weakness, because you'll pretty soon with your relaxing, your body's going to have you breathe in. That helps. Okay, I'm going to have you go ahead. I want you, because we're going to go to the sagittal suture with your left. That's enough. And now go to the, let's go to the temple. I'm looking for cranium. She strengthened on a breath in. There we go. It's over here. So I'm going to go with cranium. So land back. So does that make sense? What do you think is happening when she cross crawls? What do you think is going on? She's fine, and then she does a normal, completely normal function, and then she goes weak. IRT. Well, dural torque, yeah, but what would be causing the dural torque? The cranial stuff that we found, there's something going on with cranials. We'll start with the simplest ones first. But cranial could be from dural torque. Dural torque could be from, maybe she's got an abnormal stride, but yet this doesn't really, like if you're walking, the abnormal stride length would probably have more impact than standing in one place. Category 1 could be there. Category 2, look where the dura attaches, upper cervicals. Make sure we still have. Now she's still, you're still, but she'll start to strengthen here pretty soon because her body is now not, yes, your psoas are already back. Okay. So I'm going to have you breathe in and then breathe out. So yeah, so she breathes out all the way. So I mean, we're kind of getting hung up on cranials because they're really an easy place to go first because you get such a bang for your buck. Now, right now, her left I'm just going to go ahead. She has an inspiration assist on the right. I'm going to have you breathe in and let it go. Give me 3 more just like that. I like to tell patients, I give patients a clear objective so they don't think I'm going to just keep them breathing. Give me 1 more. Now we'll see if, yeah, you're back on. Good. Sit up. These are really fun to do with kids, with your athlete patients. We really, yeah, so everything's back on. Let's do cross crawl again. And this is slow. Kind of look out there where you're going. You're never going to get there like this, but green, how many is that? 6. Yeah. That skeleton is so creepy. Missing leg. Got it. Sure you breathe into your it's a tiny bit mushy, but it's, yeah, okay, so there's probably something else going on. Those stayed on. That stayed on. I mean, that we got lucky there because, yeah, so you see the difference. And it was just cranial. But the cranial was, now if we had her walk, for a half mile or something with the session, we might dig a little deeper and find more. But right now that's, yeah, so that's a great example. Now, when anything like that where you look where the dura attaches, you think about respiratory effects, cranial, sacral, and then after this weekend, you're going to think feet, as obviously this involves all kinds of neurological activity. Thanks. So that's another really fun way to ferret out problems. So I'm going to skip this for now. This is, we'll come back. This is another technique where you can have people cross crawl and you have them look towards that tight psoas side. The thing is, what it does is it uncoils the dural torque, and a lot of times the findings will change. But you still have to go back and find, why did that psoas get tight? So go back this, because you'll need to know a little bit about this going forward. Anyway, cross K27 is basically like we did. This K27, cross K27, deeper level of switching. And a lot of times that's associated with abnormal cross crawl patterns. Pass. Okay, so this is hopefully kind of summarizes. This is, I made this slide based on what I learned from Dr. Blake years ago. So normal non-switch person, you might have a couple of weak muscles and then a bunch of stuff strong. You have a cross crawl. A lot of times the weak muscles will facilitate temporarily because you've changed the amount of afferent coming into the central nervous system, and it's whatever aberrant factors were causing those muscle weakness will be overridden temporarily. So a lot of times a weak muscle will turn on cross crawl, and a lot of times cross crawl will kind of those problems can kind of hide from you. But if they're switched, they cross crawl and things go weak. That's over here. So neurologically disorganized for whatever reason it might be, whether it's cranial subluxation, toxicity, motions. With switched people, strong muscles all weaken and the weak muscles stay weak. So that's what we had. That last example. So just some things to think out. These are things to keep in mind, to think about when you're looking for causes of the switching. Start, neuroattaches, upper cervical sacrum, ocular lock, breath in out. Category 1, 2, 3. We'll learn 3 this session. ICD, of course, like we found on Dean. Emotional points. And honestly, it doesn't have to be in this order necessarily. It depends on the patient's history and it depends on where your style as you develop it. Body into distortion and head into distortion, we haven't really talked about. I use this a lot. People ask me, what techniques do I use every day? I use this one every day. Someone come up that has, they think they can come out. We don't necessarily have to adjust you right now. Somebody's feeling kind of out, maybe. They're having some neck pain. Something. Neck, shoulder stuff. It's a fresh injury or just sort of chronic, which is what?
Absolutely.
Oh, right. Okay. So anything in the neck, shoulder?
Yeah.
So we got a curve, and all of us have a little bit of curve, right? I mean, I don't think you'd ever find a perfectly symmetrical spine, but so that's strong. That's not. Let's have you scoot back. I'm looking for muscles that are weak. Good. Good. That was not too bad. Let's bring your wrist down and make it wrist. This is the wrist, like a general wrist extensor test. Ooh. Bring your fingers out. Now, not too strong. Let's try this side. There, straight, make a fist first. That's better. Fingers up. That's better. Still not great. So here's how I use head into distortion or body into distortion. Like obviously all the neurology in the upper extremity comes from the neck. So I'm going to palpate through and feel if there's any obvious things going on, and then I'm going to turn your head. I'm going to feel for the neck sort of softening and slackening. Sometimes you end up clear over here like that. Now keep your head just like that. Hold there, elbow straight, and kind of look that way, so that you're in line. Now make a fist. Feel a difference? Huge difference. Huge difference. Now bring your head back. So, yeah. Now sometimes I got lucky the first time, but sometimes if it isn't, I'll kind of go, I'll kind of search around and see right about there. Try that. Maybe. And that's our best right there. Feel that? Okay. So, and look at that. That long head triceps turned on. Now she needs to walk around like that. So that's a quick and dirty and very effective screen for dural core. What I'm doing is I'm untorquing spine. And that would, if that negates a bunch of weaknesses, then that's usually where I start. And this is, in practice, I use this all day. And that way, too, I can put a patient in that position where, and then I can test some other stuff. Because now they, at least with regards to what I'm finding, right now, her nervous system is in a pretty chilled out, you know, let's try that. Yeah, her brain's going, yeah, that's good, right there, hold it right there, I'm good now. And, but now, because she has scoliosis, or curvature here, I'm going to go away from the neck, and I'm going to do the same thing in her low back. That's what we call body distortion. And there's all kinds of ways you can use this. Now, hold that right there. The neck and is pretty much in neutral. Let's see what happens. Yeah, that turned on. And that's big time. Big time. That's as strong as it was. So we you know, so does she need to be here and here? Yeah, that's where she should be walking around like that. I'm kidding. But that's how, sorry, thank you for that, but we'll try to fix that this weekend if we can. Honestly, that's been one of the most effective things I've found in the game. I learned that from Dr. Lee. Dr. Lee used to do all kinds of stuff like that. He would rub people's temporal bones and just feel like a nail going in your head, and then he'd do something, and it was like you could hardly feel it. He would use pain changes in pain as a tool to find where the corrections need to be. It was really impressive. EMJ hyoid, unfortunately, I think we're gonna have to get to that next. So anyway, these are the some of the things that we're gonna we already know off their law pretty much. Right brain, left brain, and ERS. We're going to learn this weekend. Right brain, left brain is kind of fun. Let's see if we can. We'll get through that, and then we're going to test some muscles. How you guys doing? What time is it? 10:08. Oh wow. Okay. We're way past break time. Okay, let's just run through this, and then we'll take a little break, and then we're going to do some new muscles. Someone come up who's got normal, but they feel like a pretty normal shoulder. So, this is another those of you guys who are into NET and stuff like that, you might really find this interesting. So, as we know, about 80% of the neurology in the right side of the body is controlled by the left brain, and about 80% vice versa. And it's not to oversimplify, but it's thought that the left brain is logical and linear, and the right brain is more illogical and more sensory or more period. And I don't know. That was, years ago that came out in literature. It was big. Everybody saw left brain people and right brain people. I don't know. But anyway, we can test strong evidence. So if you were to count by 5, do that. We're going to count by 5. Now, I'm testing the right side. Now, count by 5s.
35.
That's good. Okay. Now, very nice. Okay, now I want you to hum a familiar tune that doesn't have lyrics. Like say the theme from Star Wars. Yeah. What's a non? Okay, you got one. Okay, we're good. Hum. No, so she's good. Yeah, so that didn't show. Yeah, you're dialed in. So she might have weakened on one of those functions, and that tells us that maybe one side of the brain needs some support. Believe that these nutrients are in higher demand on one side versus the other. If they weaken on both sides, then you look at these, things like acid, right brain, you think, modal related stuff. Left brain, C, manganese. Manganese is also important for too. Thyroid, I don't know. Anyway, try one more. Let's try one more, see if we can find something. Yeah. But they say creating people are in their right minds. Now, we get a big slime. In the shoulder. Now, let's have you count by 3s. Now, do you have a non-lyric coming to? Go ahead. Oh. So we might want to test her on today. Or do we have test kits? Somebody grab me, say 3, 4 things that would be probably like bio-CMP, cytosine E, enzyme, the enzyme. Maybe Equifem. You see that? Somebody bring a magnet. Ecofem, the enzyme, cytosine, and biosteel. Oh, sure. A couple of dummies. If it's midline, then, and that is kind of, midline would be like if she weakened, if her right arm didn't weaken to the two. But her left arm did. So that would be, for me, that the way I approach this, that would be, I would want to support the right brain. So midline would be she would weaken on this side and both sides. Does somebody have a magnet? She's just walking. She was probably got. So what am I doing? Sure, we're not dealing with a nice balance. So I'm going to have you this right here. We don't have a magnet, so we'll use her hand as a magnet and hum the tune. I don't know what I'm testing. I'm testing blind. Woo. Okay, we'll set that one aside. Okay, set it upside down. Thank you. And actually, yeah, go ahead and give us an extra. Oh. Somebody needs to invent a handy little device to, I don't know what I'm testing. I don't know what I'm testing. Big time. Okay. So everything got tested at least twice. And so the winners are FC-Silent as an antimicrobial. And then the Bio3GB, which is basically a Cataplex G. It's a B vitamin, but heavier on the niacin. So so what didn't test? Ecofem, which is the hormonal support, iron, and the minerals, bio-CFP. So anyway, so I mean, we'll set those aside, and then when we test you on some other things, we might bring it back in and see. That to me is not enough to prescribe. Especially FC-Cytal. FC-Cytal is a really good antimicrobial, but it's a hard hitter. You really tightly manage your patients if you FC-Cytal. They do lots of GI stuff. It kills a lot of stuff off. Yeast, yeah, yeast and dysbiosis in general. It works pretty well on yeast, but there's a couple other things I think are a little incrementally better place to start. FC-Cytal is like ADP, which is the oregano, works so well, but if it doesn't, then we can step up to FC-Cytal. I'm going to set those. I just remembered that we. Okay. There we go. Anyway, so thank you. Anyway, that's long and short of right brain, left brain. If you ever go for AP diplomat, you need to know this. Whether you agree with them or not, you need to. Oh, is this? You mind if I hang on this for a bit? So let's we can take a short break, and then we're going to learn how to test. We'll go back to this later, but we're going to learn how to test quadratus form. Oh, no. That just switches to the other slides. Anyway, let's take a short break and. Yeah, honestly, I do understand. It's not like
I can Yeah, that's awesome. Thank you. Should I just like put them in chips? Oh, this no. This is my food. This was my food back in the day. Well, it's gone now, but it's gone. It's only like the place that has the free like fast food. That's the thing. But it's like really good. I like get out of this building. My head is like. And this morning I woke up and I had like vertigo like symptoms. It felt like BP. And I was the whole room going like, yeah. I woke up and I was like, whoa. And then I just like sat there and I was like, but then when that happened once, I called Elle and I was like crying. I don't know what's happening. I have this thing. Like, am I gonna die? I looked at my husband and I was like, yeah, same. I was like, I feel not right. No, I did nothing. I went to her house last night. And I didn't eat a lot of sugar, and I don't drink, so I didn't drink. And I didn't eat a lot of sugar because she has blood sugar. And I already have like blood thingy, whatever. But yeah, fun stuff. I was like, and we did the face acupuncture, like the head. Ever since that, I don't know about anybody else, but ever since that, I've been I've been like laying down and just like all the energy you put points in your feet when you do points because it like fucks up your energy. Well, that's nice. That's good to know. I wish they like enforce stuff. Oh, maybe that's why I feel the way. I wish that they would have told us that. We could have just done that. Because me and my friend were like, I almost had a syndrome. Fucking game. Wow. My friend like threw up. Like she's like, take that one out, take that one out. I gotta go throw up. And I was like, damn, I almost passed out. She put gallbladder 8 in mine, and I almost passed out. I was like, she need the nerve. No, I just immediately just like flushed, got dizzy, and I'm like, take that one, like your phone.
Which way did she do it?
She went this way.
Never do it back. Because I did on her one time, I went the opposite direction. And same thing. She got super dizzy.
Damn.
You're what? Yeah.
Exactly. And then I'll run into a patient. Where you recognize, I can even tell you what's wrong with her. Might be wrong with that. But I can't remember her name.
You're more really not. Yeah, it's like, I think it'd always be like, really? My name's what's your name?
Some people, it's funny.
You like you don't know their name.
Most people know.
Stop.
And they don't quite get it. And that's, most people will offer their name. I won't even go into this yet.
And it's like to a ridiculous degree.
And they all just, and a lot of them assume that I want to stop and listen to them.
I will be. Yeah. Or ask me.
I'm just there to grant it.
But I'm gonna start like right now. I know. It's so fun. That would be right next to you. But I think there's a big it was so tiny, and I was like,
I have made all.
and it was like, or it's hard because like you can study on.
I have made all.
I felt better about electives than I did.
But I made a lot, and I learned. And it's part of the genuinely find them beauty.
But yeah,
And you see them and you have this intimate and they really trust you and they tell you all kinds of weird stuff. And it's like it's not. I've got years.
Making deals with whatever higher power is like, please.
I can't do this again.
She loves.
Yeah.
She's like she's young. She's got kids.
It wasn't that
But
like the timing was more
is so
of the
friendly.
problem that
Some of my patients are really
I did. There was one
you said
day
the
before
first
that I don't know where I was
engage
but I got like 20 minutes.
So the next time
like
we
the
might
back.
be busy and
Yeah, like I had been making
just
notes. I was so crazy. I have no idea what.
so she's
I have no idea.
Some of my patients come up and
I don't know what to say. So
she
just close your eyes and be like, good. I've seen that before.
really
We're gonna go with that.
and just short people. And so a lot of my
Oh, well, good. How are
patients
you? This looks like I have something I've seen.
I know. Yeah. I know this one. This one I've seen.
Like, this one is something we learned.
yeah, I
And then for elective farms, everyone
Patient
should use course farm.
patient
So for half elective farm, like never but I guess you're gonna be
I guess we're prescribing that.
like that sounds good to me today.
Right, goodbye.
You've seen that ending before? Yeah. Like you have to refer back to this.
but they get and they get really good results.
Yeah. I don't know.
But they
I'm
know
gonna need like a glass of wine this big.
I'm thinking the family size. Yeah. Just, you know.
Yeah, it wasn't that much. The light. Sorry, running late.
I like looked at you quickly and then I was like, tech robots. I was like, glanced at her, didn't acknowledge her.
It felt like boards, like not great, but
it feels like that.
yeah.
I felt like good leading up to it. I felt horrible during it, and then I felt good after being done. I felt horrible. I cried that whole like Friday night. I was like, why did I not study more? And then like I felt bad, like and then like that was hated the results. I was like nightmares, anxiety,
I'm like, but yeah, right now I'm like, life is good. Like, I'm happy go lucky. I have to do something for the next 5 weeks, so like, let's not make it panic attacks, ideally. And then, the week leading up is gonna need to be medicated.
Girl. Anytime you want NET, I know she's certified. So.
Are you really?
Yeah.
Wow. So exciting.
Also, I was
Yeah, I think so. Yeah, I think just.
so was not crazy, girl. Was not. I was like.
It's fine. Honestly, it's kind of hard to. I didn't even know like how to prepare for that. He's like, I just want to watch you work. And I was like, I don't know what that means.
We had to actually watch an action, but I just went about it like I was like, okay, I gotta show my notifications, and I just
Should have done what you want to do. He's so I'm sure it'll be fine.
yeah, he is really cool.
He's great.
Dude, one day I'll win.
Oh yeah, you 100% will. He's not a tough egg to crack. Oh my gosh. I need to like get all of my stuff organized with the practices that I'm working in, like all my intake forms, bios. Yeah. One on the west side, and then
love it, yeah. It was a good night for her.
well, the one that's on the west side is the office that I worked in before I started here. And I don't know, when you come to South Africa, there's a lot of locations out there that want to see me. So I said, fine, I can split my time between here because I have so many students that I see and then yeah, so I'm just having to get all my stuff organized for both of those. And I just needed a couple of weeks. So it's going to be a couple of busy couple of weeks.
I know you were in. Are you still in?
No, I'm in like the Biltmore area. Yeah. I love it so far. But I really like it. I love it. This is home. It's been asking more. But yeah, I'm really liking it so far. No, I live by myself, and I was so thrilled to live by myself again because I've been living with roommates for.
But I was like, wow, awesome with my life. You have fun painting. Rachel.
And then, yeah. And then I was like, well, I'll be like working and actually making money and living my life and still let me live by myself. Thank you. We'll have to have like a
Good.
Yeah, I can tell you were feeling well.
So that's life right now. It never stops, but here we are.
That's the only thing he was upset by was the green.
Okay, it's charging. Wasn't charging.
Honestly, the
Anyway,
studying
so-
was fine. Like,
No, like
we were only like 12 to 14 hours
This one I couldn't
every
get.
week and
Words
like
weird.
yeah.
Usually
So like that's what I'm thinking. Like if for heaven forbid, like if something didn't go well, like I just
My sister said it was, my sister's been dropped the phone. I usually don't get hit by weather. So we tried different things. Then we got told by day 3 I was shot.
we were like manic the entire. Yeah, it's so
what did you try?
yeah, it was
Lots of
25.
manipulations, acupuncture, lots of acupuncture.
so much more concentrated. If I don't pass,
Try to stay
four
safe,
cards.
but
Yeah.
You know what would have been
like
worse
this
for
morning,
man with
I slept for 3 hours last night.
Not for me. So I just train every day. Way, so might as well just like live life and then.
Chair was like pushing me. They just sit in the truck, yes.
Yeah.
And I sat there for 2 hours so then I went off to get in the shower.
I appreciate
That's
that.
like the first thing I did in there. So I had just 2 hours.
Yeah. Yeah, you did a lot. Do you feel like, I mean, I don't know what. Oh, no, I have. I was asking him about his migraines, but I was like trying to like think of something that could potentially help. Like, it's like so bad. You're not, Donby's just not walking around all the time, you know?
That's just part of it. That's just when the migraine breaks. Your body
Just like relaxes a little bit. Yeah.
so I'm saying,
Do you like have anything?
oh, of course. So I'm trying to wait till I drink my water like a good boy.
Oh, you have caffeine? So I figured you would. Do you take adrenal support? Okay. I feel like most of us.
And I've been taking this one
I like this. I use this too.
Trying to understand
It's like different
how they're perceived.
adaptogenic orange, green tea, green tea. I do it like as a little boost during the day when I feel a little tired. It's pretty like gross tasting. Yeah, it's not great, but I like it.
Clearly.
I bought another one. This is the last of this one. He's like, I'll try
Can't
it
do
again.
anything worse than what I do right now. Like
So,
that?
yeah. So on you, it was like saffron and oxypod. I feel like this oxypod is always out. Or like regularly. Yeah, it's bad. You might want to drink some water.
That was delicious.
Are you kidding? No, he's kidding.
How you doing?
Gross. Good. I'm tired.
Tired? Hurt your back?
Yes. I have no pain. My eyes are open. I see everybody's face again. But then
I think he found temporal bone and
ankle.
I think that's
Just gave me some really nasty stuff. It's supposed to work to wake me up.
I think
And I
the
think it's
taste
just because
itself.
the taste.
Yeah.
The taste itself is so
Absolutely
bad that it just shocks your system.
What is it? Some kind of nasty?
Vitamin the liquid form. A tincture.
Oh,
Yeah.
what's in it?
A lot of like adaptogens. Yeah.
Oh, okay.
So like.
Which smell like dirty socks.
I think
Yeah.
so. Yeah.
It tastes.
Can I smell it? Can I smell it? Oh,
You want some too? You can take some.
you mind? You mind if I have? Oh, it's mine. Oh, yeah. Okay, sure. How much should I take?
Probably just a full dropper full.
Really?
Yeah.
Really?
Yes.
Yeah, bring it on.
I can't.
I
I can't.
dose you if you would like.
No, that's a.
Is that enough?
Yep,
That's
that's
good.
Okay.
I do too when I take mine. Yeah. Yeah. I
Oh.
got down.
Told you.
Oh.
Now you've been adapted.
Yeah. Say,
See, now you're awake.
it's very familiar. Oh, baby.
Oh, baby.
Oh,
Dr. Dom, you had a couple
my tongue.
questions.
Have you ever had
Yeah,
ever
it's
eaten
really
choke cherries?
Yeah.
Choke cherries?
So. Yeah.
They're like a weird little berry with they're mostly pit. They're the most tart fruit in the world.
That's hilarious. I had a question. Okay. So if the patient you test K27 and the umbilicus, it'll be weak, and then you
If
rub
they
it out.
need, yeah, if they need that, yeah. It's
So
like
they test this, it's weak. They do this, it stays weak.
with somebody, this was positive and this wasn't.
Yeah.
But this stayed positive. So then we went with
This
that.
was weak, I think.
Yeah.
And then they TL'd this. If it was positive, it'd be weak.
Most
Yes.
of them are.
Okay.
Yeah.
But hers was strong.
But it's mostly.
Hers was strong this way.
And then, so you would test like a leg muscle to do this one.
Yeah.
And so if it was weak, then you would do like
Yeah.
the, okay.
Stimulated. Yeah.
Okay. Then, and I have one more question.
Yeah, it does taste kind of bad.
So it was a strengthen with the breath in. You TL the mastoid to figure out which side.
Oh, to do the yeah.
Can you? So
What you do is TL. If you have if you breathe in and it straightens, or if you breathe in and it weakens, whatever,
Yeah.
then if you have a change in muscle strength with breath in and breath out,
yeah.
you TL that.
TL.
If that negates that weakness, now it's strong either way. That's
Ah.
the one you test, and you know it's a breath in because they strengthen on the breath.
Okay. To figure out side.
I actually, where'd Dean go? Or who's maybe L? Hey L.
Yeah.
Hey,
The licorice really comes out of that.
Yeah.
Yeah, she has a good palate apparently.
Yeah, that's probably the most hidden one. I'm like, you taste all of like the.
I just
Really?
taste like.
You don't taste the licorice in that?
No, I taste like the ashwagandha and like the aleuthero, like the very like bitter like.
It is bitter, but I guess at the end of I definitely taste the licorice.
Yeah.
In that.
Her palate kind of. And I'm like,
What did you ask him?
I
I was trying to listen, but.
so K27.
Yeah.
So I was like, when do you know if the umbilicus is involved? He said like, so if K27 is weak and they TL the umbilicus and it's still weak. So then you're like, the umbilicus is involved, and then you rub it out,
Yeah.
and then it should be strong.
So I wonder. Should have asked him, but I was thinking if that like indicates that they're like what does that say about like their CBH?
Yeah,
You know what I mean?
Yeah, that's a good question. Hi. Hello.
Like,
Yeah.
It's so good to see you.
It's so good to see you
Always.
always.
Yeah.
Aw.
it's like a breath mint.
You're so wonderful.
I didn't like
Yeah, but the end's better.
Yeah.
Yeah, they have it.
No, please God. No, there's so much wrong with it.
Do you do like a lot of
Girl, more right than wrong. More right than most people too. And you know me. I feel like you know me personally. I'd be like,
I need a little bit more of that. I'm
you're
like,
I was at 8. You're like, you have shadowing at 8. I'm like, it's 7:58. We have so much time.
you're like, yeah, I'm just gonna shower really quick.
It's like, oh, I'm actually gonna jump on the trampoline.
I'm actually gonna go for a walk. I'll be right back. I was like, sounds great. I guess it works, right?
Oh my God.
They were living the Hawaiian lifestyle anyway. We didn't leave until
so
fun.
It's still like one of my favorite trips that we've done during school.
I know. I thought about it the other day. I was like, wow, that was so fun.
I wish they were still there. I would visit them.
Oh yeah.
They're in Texas now.
Are they? Did they finally move? Okay.
Yeah, they like each in the evening where I found it. This weekend.
Tomorrow we're getting on.
Okay.
Is it time? Here we go.
Sadly. I mean, not sadly. Great. I'm so happy. Oh.
So are we ready?
Kayla had one more question. She said that like if you do K27 and the umbilicus and it goes weak, so there's involvement of the umbilicus. Not the that point.
It's basically what you're doing is you're tuning up the relationship between the conception vessel, and the kidney. So it's kind of a,
She was curious why.
yeah, that would be my take.
So K27 is weak, and then the TL the umbilicus, and it stays weak.
So here's how you can be weak. Maybe we'll go over this because I think you're not the only one. You're not the only one. So,
Especially so, guys, you ready? Are we ready?
Oh yeah.
Are we? So ready. So, Michaela was asking me a couple of questions, so it seems it might be a little confusing. So, there's a number of different ways that we can be switched, and there's a number of different ways to sort of determine if the patient is switched. One of which is TL, bilateral TL to K27. And that's kind of a general kind of switching. Now remember, all of these techniques were sort of developed and evolved over a lot of years, and it's kind of like different ways of addressing the same phenomenon. So somebody came up with this one, then somebody came up with the bilateral, or the K27 and umbilicus, and then somebody came up with cross K27, which seemed to be like a deeper level of switching, and then started correlating it with cross crawl. Somebody came up with the head turned with the eyes right, as a screen for, so any of these can be screened for if you think your patient is off somehow. If you're doing, and when you want to really lean on these techniques is when you've done the real obvious things. You've cleared categories, you've cleared maybe the major supplementations, addressed ICV. You've really kind of cleaned up a lot of real obvious things, but then they keep flipping back into their patterns. That's when you want to look. Now, honestly, my personal preference as far as switching goes from like the most basic, this, which I didn't learn at AK. I learned that from Dr. Brimhall, who was an AKer, but he's got his own show going. He's from down here. Yeah, any of you guys know who Brimhall is? Dr. Brimhall? John Brimhall? He's from down in the Tucson area. Anyway, he was one of the old-timey AK diplomates, and then he kind of went off and he's got his whole own show. But he does that, and I learned that from him years ago, and it works really well. That's a quick screen, but then I really like having people cross-crawl. That ferrets out a lot of issues, especially with athletes, along with like the gait testing that we do. Upper trap, lat, piriformis, SCM, gait session 1. And then I really like body into position and neck and head into distortion. Body into distortion and head into distortion. Those for me are my go-tos for clearing switching. It gives you access to the other things that are going on in the patient that you might not get other examination. So, just like, if you adjust someone, you clear their category 2, for example, then you have them go walk around for a bit, that's going to bring back underlying problems if you didn't clear what caused that cat to foot or knee or something else. So this is kind of similar idea. So we're going to learn some new muscles. The QL is related to the large intestine, like what other muscles? What else is related to the large intestine? Big movers. Hamstrings. TFL, both related to the colon. This more specifically is related to the, what's on the large intestine already, but it's related to the rectum, supposedly. And so it's not, it serves supply from the lower thoracic, upper lumbars, like the psoas and the quads. Anyway, you can see it. Let's see, I think this next picture, oh yeah, you can see it more clearly. See, right there's the QL, and then the ilium costalis lays right up against it. QL mainly is there to sort of give stability between the ribs, spine, and the pelvis. It's a really important muscle, and it's often overlooked. It can get really tight and cause all kinds of low back pain. And a lot of times it's sort of out of the way enough that it doesn't get addressed. The way we test it, so it elevates the pelvis. If this is fixed, it does this. If this is fixed, it does this. So, and the way we test it is we put the patient like this and we bring them back. It often will be tight when you have disc issues or any other kind of like a facet issue. You've got a chronic low back joint problem. A lot of times this muscle will be overly tight, trying to help stabilize the spine. Brain tells it to just lock down to prevent aberrant, painful movement. So anything low back or pelvis, consider this muscle. And of course, posture. You know, you're going to see something like this, and you might think, okay, category 3, which we're going to learn about here pretty soon. Category 2. Category 3 is like this, so either one of those could be suspect. Pelvic imbalances, just any kind of low back pain, you need to check this muscle. There's Dr. Rob, the way we tested. If somebody could come up, I'll show really quick. Somebody with a QL or 2. I call it QL because quadratus laborum is just too many syllables. Let's have you stand first and see if there's any indication. So, so we're just looking for anything real obvious, and I don't see anything real obvious at all. Good lady. A little bit, if you side to side issues, a little bit, maybe a little bit there. But. So I always palpate the muscle, see if there's any trigger points in it. Now remember, you've got the the posterior Chapman reflex for the kidney and or for the psoas. Got the adrenal Chapman reflexes back here. That's tender. Not so much. So that one's tender. Now that would indicate that's probably the tighter one. So good pain on the right. So the trick with this, and this is where a higher table is really, like something like that would really take it to save your back. But you can put your arm underneath, or you can put it on top. I kind of like to do this because then I feel like I have a little more control. Plus here, these tissues are a little more sensitive, shin, so you might get a false positive. Make sure you're really stable and not overworking your own back. Come in through here, and I'm right at her trochanter, and I'm going to use that as a fulcrum, and I'm just going to bend you over this way. Okay, now hold that position. I'm going to try to straighten you back. And there's a weak one. Now, just so I don't overwork my arm, I'm going to kind of lock in, and then I'm just going to shift my weight. And you can test some pretty big people that way if you don't. There's no way to test them both from the same side. So, now that was strong. Last session we talked about the triad of strain sprain, right? Had a primary weak muscle that was possibly a result of some kind of trauma or strain, and then you had a antagonist that would be hypertonic and often fascially congested. And then there would be often a synergist that would be overworking, trying to compensate for the primary muscle. For that last time we talked about triad, spring. So this side is weak. I want to see if this side is hypertonic. How would I know? Stretch it and retest it. So hold there. sure that's strong again. Now let it stretch. And then hold again. Yeah, see, it doesn't like it. Now if we let it set for a little bit, hold, it comes right back on. Give it a little stretch. Hold, doesn't like it. So she has that. Now, what would be a synergist to this weak one over here? Possibly. Could be iliocostalis, or the rector spinae group in general. Right. Oh, let's see. Well, that's, here we go. So these are, I'll use these up first. Hands are so dry down there, I can't grab paper. So this is another one we're going to learn here in a little bit. And this is the group muscle test. This is the largest group that we're going to test. You have the patient lift their shoulder. Now bring your head and neck up this way. Hold that position. So then I'm going to come down here and stabilize, broad contact, press here, hold. Try that again. So this is the type. That's interesting. Okay. Bring this up again. And so her left sacrospinalis group is weak. And her left QL, right there, is tight, is hypertonic. So would you touch, can you touch right there? No, you can't keep that. Lift your shoulder up. See that T, we get a positive TL. So I need to fix both QLs. I need to fix the weak one and I need to fix the tight one. And then we'll retest to see if that erector, before we treat anything to do with the erector spinae. So the weak muscle, which is on the right, I get dyslexic when I turn the patient over and I can think for a second. Okay? I'm spindling up for QL. And it's a short, thick muscle. Right now. Now, I'm spindling that up, but I'm going to see if it had the right effect on this there. So there, that's the right QL, which is weak in the clear, for left sacrospinalis are reactive muscles, which we're going to go over here in a second. They're what we call reactive muscles. So I need to fix this one, which I think wouldn't lay you back for me. I think we've spindled it up enough. And yeah, big difference. Now I'm going to give it a little stretch, make sure, hold there. No, that's good. Now we'll go back to the tight one. See if we need to fascially flush yet. Good, let it go. No, it's still laying your right side. So fascially flushing the QL, I find it easier. Good, bend your knees, give you more stability. I'm just going to go in. Okay. I'm just basically doing an effleurage. Now, she might need her low back adjusted. I haven't really checked for that, but. So make sure this is still strong. Oh. Okay, good. And stretch. There. Stand. These are not the easiest examples to work with when it comes to strain, triad, and all that. There. Now that's pretty good. Let's go to the other side. That one's actually. So I'm going to spindle down this tight area right here in the flat thoracolumbar region. Actually, I got it out into the weeds a little bit with this, but I wanted to show you how the relationships are. Make sure that's happy. You can make real changes in people's chronic low back stuff if you find this. Find this. Find this these relationships and fix them. A lot of times you can clear really long-term lumbar issues. So what am I doing now? Testing for someone. Neck extensors. Because I just got done working on her lumbars. I want to make sure I can't let her go until yeah, so she's got a lumbar fixation. Can we go ahead and fix that and then we'll go. Okay. Lay face down. So how would I go about determining how I'm going to adjust her low back? What we all know. I mean, there's several different ways. What would someone suggest? I mean, I know how I would do it, but did I use a strong indicator muscle? Maybe a hamstring? A big knee. So those are strong. Let's try a piriformis. That's a really handy one. That's kind of weak and clear. That might be a good one to test against what? Inspiration? Against pelvic categories? Against lumbar subluxation? We know she's got fixation as a neck extensor weakness. TL your bilateral SI split. Just like that. Nothing happening there. How about just a single-handed? Remember this one? Single-handed TL is category 2, and that's turning on a piriformis. I got lucky. Now do that on this side and see if I'm. Yeah, so that's. No, that's. Oh, sorry. Which one? Go back to this one. Yeah. Okay. So she's got a cat 2, but I think we need to address the fixation. And if you remember last session, fixations were palpate and you move the spine and you look for where it's kind of stuck. And there'll be a top vertebrae and a bottom. Last session. Right there, that's her L1 is stuck. That's the top one. It kind of moves that way, doesn't move that way so much. So it could be posterior on this side, but it's pretty spongy. It's anterior. So if it's anterior on the stuck side, you go to the bottom vertebrae and you adjust away from the top. So I want you to lay on your right side. I'm going to do an adjustment on her L4 away from her at 3 and 2. You guys all with me? Trying to integrate what we're learning here. If you're not with me, stop me and ask. So if you guys want to come down here, I'm going to show you how I'm going to do this lumbar.
I wear them on days where I feel really tired too. So you tend to be on the weekends.
The bright colors.
That's kind of not good.
Okay, so it looks like a regular lumbar adjustment setup. And so this is the top vertebra here. This is the bottom of the fixation complex. So I'm going to be on this L4. It's right between L3 and then I'm going to push into that and then then I'm going to push. See what I'm doing with my upper hand? Lock that and push her away. Pretty good. Then the other side, because I want to make sure that the upper one is moving, and this is where I'll use like a spinous pull, which isn't for everybody. Spinous pull is where I get on the spinous process. Now, a lot of times I'll have their leg like this. This is a little, it's a little easier. So right there, so I'm kind of letting her leg down. I'm hooked underneath the spinous. I'm going to bring her over, and then I'm going to push up, and then adjust her. Okay, that was kind of stuff. That was the upper. But I don't. If they're stuck anterior, I don't want to push it. Try to pull it out. If they're rotated this way, they're stuck posterior. So maybe sit up. Now we haven't looked at hopefully that might have gotten rid of the Cat 2 finding back. Well, I choked choked her out. No way to find a weak muscle. Sorry about that. So if I don't choke her, actually, it tests really well. If I do choke her, of course. So now let's see if we have. So that's another piece of information chart. Choke patient didn't like it. Didn't help. So she had where was that? Was it on the right side? Yeah. So she's doing a single-handed TL, but she still got the Cat 2 laying back. Somebody tell me how to fix her Cat 2.
Block it.
Block. Which one do I block?
Check the leg.
So what am I looking for?
All right. Short leg.
Short leg. So short leg on this side, which makes sense because that's the side. So I'm suspecting that it's a PI. Then what do I do? Right, exactly. That's what I want. And that's why I'm asking you guys. Yeah, you're right. I do. So, can you pop these up? Some serious footage with those hands. It's just a really interesting combo. Class. You're a fashion cutting edge person.
I don't think that's
Thank you. Baggy pants have come back big time, I've noticed. I've been through the baggy pants and the bell bottoms several times. I remember a time when all my pants, all my blue jeans were bell bottoms. This is a long. Oh yeah. For years I had long hair. I couldn't see it. Yeah, it was. So she's short on the right. Now, I don't think you're anatomically short, are you? Yeah, let's see if we got a strong indicator. Strong there. Go ahead and TL the right SI again. So that just double verifies. Now, so UMS. Just to be overly awesome. And then medial tenderness. Okay, sure. Now, an AS would be what? LLL. Long leg, lateral knee tenderness. Right. Just, so how are we going to fix that? Do we have record blocks? So how am I going to place the blocks?
So UMS is PI?
How do I do this one? This is the PI side. Straight in. Now what about this? Okay, so we didn't have a weak muscle to strengthen. We didn't have the performance, but we tested it probably. So we're testing it now. So I'm just going to let this simmer for a little bit. Now, do we leave category 2 blocks on a long time? Really not. It usually clears through. If you leave them on too long, you might not category 1 block. I'll fall asleep. But at some point, they quit making a correction. Same with these. At some point, the correction is done, and now body. That's weak again. We did that the lumbar fixation. So it, yeah, let's have. Doesn't show, and unless she has an anatomically short leg, legs should be even, and they are. They are. So go take your hand away. So that was excellent. A lot of times I'll do this, shake loose, she's injured that ankle. But yeah, because this got some rat. Hold that right there. What did she have? There's from last session. What are the fixations? Very good. Why do I say that? Because all of the other ankle muscles, ankle muscles on one side will be weak. Now, maybe it's an ankle local problem. TL your left first rib. Now TL your C7. And up and out. And down. And we didn't test this one, but we're going to learn these in just a little bit. Push out. So she has a limbic fixation. Probably from walking around with a PI pelvis and a fixation in her lumbars. So, and then the dural torque makes its way up and it either sets up shop in the upper cervicals or the first rib area or the sternum or maybe the TMJ, actually the cranials. Doesn't usually need much. The whole T7 away from that. There we go. That was it. Now, if you look for these, get good at these limbic fixations because if you look for them, you'll find them. I don't know if I find them every day, but I find several a week. But only because I look for them. And I treat a lot of extremities, so I end up, a lot of times I'll be examining an ankle. Those are all fine. So they'll come back on if you fix them. Okay. So we started with just testing the QL. Found out it was imbalanced right to left. Then we found out you had category 2, you had a fixation in the lumbars, upper lumbars, and you had a limbic fixation of those. Yeah. So, lumbar fixation, category 2, limbic fixation. Yeah. So, anyway, I want to run through, we'll go through the muscle slides, and then we're going to learn QL, matrix analysis, and all the before we do lunch. When do we do lunch? Yeah. Is there anybody know the correct time? 11:30. When do you guys want to do lunch? 12:30. Any questions on what we did there? Yeah. I didn't. Yeah, it was positive, but we didn't check that. Should have come back.
Oh, okay, so it would have been strong.
It should have been strong.
And then when it was,
Now, when you're clear, when you're checking for Cat 2,
It would have been
Clear.
strong with the block.
Okay.
one of the ways is you can go back in, you say, well, how long, I don't want to leave the blocks too long, how long do I leave them? Well, leave them for a little bit and then check the upper fossa TL again, or lower fossa if it's an AX. And then it'll go weak again, then it's time to take the blocks out. I'll look, another way is you can challenge, it's a little touch here, but you can challenge, you can just go ahead and challenge the pelvis too. Something like that will. But the upper fossa is the best, and then look at the legs lengthening. The legs will lengthen out, and they'll even out with the blocks under them, and then you know the correction's happening. And the medial knee tendons will often go away. So let's run through these slides. QL, this is how we test it. Dr. Rob, he's reaching over the feet, that's fine. I think you really got to get low to get a good pull. If you did them like that, you'll miss a lot. Yes, and you won't make your back very happy, as an example. Rob's doing that for the picture. I know Rob's an excellent muscle tester, but there's the Chapman reflexes and the lymphatic reflexes for the QL, and also those are related as close to where the adrenal Chapmans are. There's all kinds of stuff going on there. If you don't know what the heck to do with your patient and they got low back pain, just go in and work on the thoracic lumbar. Just massage it, motion it, heat it, you know, wave a wand over it. You will get, they will feel better. Now, maybe you didn't get to the very, you know, bottom of their problem, but they'll get their money's worth. I threw this in here in case you guys need it. I would recommend, I've said this before, I'd recommend I stole this right out of Walter, literally lifted it right out of Walter, so I should have a note in there, disclaimer, but have one of these handy, laminate it, have it in your notes, have it wherever you practice. Do the same thing with this. This gives you, that way you're not looking at these things isolated. If you start to look at these Bennett points, you'll see whole patterns like this one right here. These are all adrenal-related muscles. Except for the tip posterior diaphragm, but you got soleus, gastroc, gracilis, sartorius, all adrenal, right there where those two sutures meet. And you go over here to the top where the brainlet is. These are all lung, brain, and lung, brain, and diaphragm related, lung and brain related muscles. And after a while, you'll start to see these patterns. You go up here to this one right here, glute medius, TFL, QL, and quadriceps and piriformis, all right there, that little eminence on the temporal bone. Kind of raised area. It's where if we had horns, that's where we would grow horns out. And there's, yeah. So there's the QL Bennett. You know, I've mentioned anatomy trains, and somebody is familiar. Some of you guys are familiar with anatomy trains, right? There's the lateral line, the lateral fascial line that they talk about in anatomy trains, comes right up through here. So a lot of times when I have kind of weak abductor muscles and I'm not getting them to fully come back on, I'll come up on hit spleen 21, which is on that lateral line. I'll come up into the side of the neck and right up into the temple. And a lot of times that's where I'll find points that are trying to turn on that muscle train. And I believe that has to do with the fascial train, which also has to do with meridian, the myofascial meridian. Anyway, the nutrition is A, C, and E, calcium. You need to know that for your test. It's your ace in the hole for low back pain. Well, that's what Dr. Francis just said. Your ace in the hole for low back pain. So remember, ace. High ribs. Anything here. Check the QL. Sacrospinalis, we just tested those. I love this picture, so I put it in there. Excuse me. It just gives you a real nice kind of idea of how these, you know, that's our posterior support. When we get into feet, you'll find that so much of the problems with the erector spinae has to do with it. So originates all over the place, inserts into the ribs, the TPs, all the way up to the occiput. It's everywhere. The erector spinae, if they contract unilaterally, we get extension and rotation. If they contract bilaterally, we get extension. This breaks down all the different muscles. You learned all these in Gross Lab, I'm sure. So any of these muscles could be part of a dysfunctional extension chain. And remember the deep ones, the rotatories, the multifidi down into the rotatories are the ones that are really involved when we find subluxations and fixations. It's those little tiny muscles that lock up vertebrae and disrupt the normal flow, motion flow through the vertebrae that we're really addressing when we do this. The outer muscles we're addressing when we do trigger point work. Yeah. We're doing adjusting. We have to really be aware of how we're affecting those muscles. So ACE, vitamin A, C, and E. It's on the bladder meridian. Of course, the bladder, really called the dew points, the associated points, the two rows of acupuncture points along the spine. Chapman reflexes are just straight out from the umbilicus. You've got the bladder, and you've got the kidney, and then you've got the adrenal. And then right on top of the symphysis, then L2. And then the gastron, we're going to head right into that. So I showed you how to test it. The extensor group, sacral spinalis. I'll go through these and then I'll demonstrate these, and then we'll all learn these. So gastrocnemius, another muscle that's often overlooked with knee problems and ankle problems. Remember, this muscle pair crosses both the knee and the ankle joint. So it's a big deal. Just like the hamstrings cross both the knee and the hip joint. And so, of course, the soleus underneath that works along with it, the soleus only crosses the very extensive origin and single point insertion. It's an adrenal related muscle, and it's related to the CX meridian, pericardial meridian. So yeah, I threw this slide together. Anyway, these are, you always think when you see a bunch of these muscles, we always think of adrenal. So sartorius supercilius, the tib posterior, soleus, and gastron. The tib anterior, though, is related to the bladder. Plantar flexes the foot. It also aids in knee flexion. More than anything, it sort of prevents knee extension in gait. Classic. I saw a guy in the lobby this morning. I was waiting to get picked up by Alan. I watched this guy kept walking forth. I think he was getting picked up, and he was like this. Man, I wish I could invite him to our class, because I mean, he's like hanging off his gastron, and his back muscles are just kind of